Bismillahirrahmanirrahim. First of all, I must accord a very warm welcome to the newcomers. Today I am going to discuss with you bleeding diathesis in children. I am Dr. Khalid Mahmood Ahmad Khan. The flow of my talk will follow this pattern. We will be having an overview of homeostasis in the blood clotting process, how to approach to a child with bleeding disorder, what are the laboratory investigations, and what are the common bleeding disorders in the pediatric patients. And we will be talking in context of coagulation disorder, which will be acquired and congenital one, some platelet disorders and some vascular disorders. Before I begin my talk, let me emphasize that the blood is an important liquid tissue of the body. The normal fluidity of the blood is maintained by an intricate balance of procoagulation activity on the one hand and anticoagulation activity on the other hand. Thus, the fluidity of the blood is maintained so that it can flow into the circulation. The process of blood clotting and subsequent dissolution of the clot follows four important major events, which includes vascular constriction, whereby the flow of blood is limited to the injury, the platelet aggregation, where blood platelets adhere and aggregate together and they form a clot. Remember, the platelet is something like a factory and has so many chemical mediators. Then there is a clot formation to ensure the stability of a platelet plug. And finally is the fibrinolysis pathway, so that the clot must ultimately dissolve so that a normal flow of the blood can be ensured. Now this is apparently a busy looking slide, but it's relatively easy to understand. But what I would emphasize that these clotting factors in the blood, which are numbered from 1 to 13, one student should try to remember it at least once, because then it helps in understanding how the homeostasis mechanism is going on. There are three important pathways. One is the intrinsic pathway, the other is the extrinsic pathway. Both of them culminates into a common pathway. Now what happens that after a surface contact, the factor 12 is activated to 12A. 12A then activates factor 11 to 11A, then 9 to 9A, and then in the presence of factor 8, platelets and calcium, ultimately the common pathway factor 10 is activated to 10A. On the other side of the coin, the extrinsic pathway, in the presence of tissue damage, with the help of factor 7 and tissue factor, it also converts factor 10 to 10A, which is the common pathway. The subsequent steps are whereby this activated factor 10A converts prothrombin into thrombin, which ultimately acts at the final steps in which fibrinogen, which is more of liquid form, changes into a semi solid form fibrin. And then this fibrin has to be stabilized, which is done by factor 13A, and then it forms a stable fibrin clot. As I said, these clotting factors, one should try to remember it at least once. Factor 4 is calcium, not highlighted here, but the important thing is that factor 6 does not exist, so it is conspicuously absent is the factor 6 here. They all can cause individually as different diseases, so remembering them is always helpful. Now, what is the approach to a child with bleeding disorder? The history is of ultimate importance, because the history is going to determine what is the site or sites of bleeding, what is the severity and the duration of bleed once it starts, what was the age at onset. The earlier in age a bleeding disorder starts, it implies basically that the process is of a certain severity. Was the bleeding a triggered one, or it is a spontaneous? Any previous or personal or family history of similar bleeding problems in the family? Did the child or an older individual has unexplained, out of proportion, severe bleeding on him after a minor or a major surgery? They all basically points towards the possibility of a bleeding. In the physical examination is basically done to find out the pattern of bleeding disorder. It's a clotting disorder or it's a bleeding disorder, because the mucous membrane bleeding and only bleeding into the skin may be a manifestation of a bleeding disorder, whereas a hematoma formation and deeper bleeding points basically towards a clotting disorder. The important physical signs of petechiae, purpura, ecchymosis, hematomas or hemarthrosis or mucosal bleed, basically they are the clinical pointers of a bleeding diathesis. Petechiae are 2 to 4 millimeter, purpura are anywhere between 4 millimeter onwards, ecchymosis are larger bruises, hematoma is basically a palpable collection of blood. Patients with von Willebrand disease or patients with platelet function defects predominantly tend to have a mucocutaneous bleeds, whereas clotting factor defects like factor 8 or factor 9 and factor 11, they tend to bleed into the muscles and joints. The physical finding of lax joints and skin elasticity with skin bleeds may be a pointers towards a vascular pathology. What are the lab investigations that are helpful in determining the bleeding diathesis? The first and foremost is the simple blood count and film, in which the important things to look at are the platelets, their number, because the normal platelet number range anywhere between 1,50,000 to 4,50,000, and then any other abnormal cells in the white cell series may be a pointers to leukemia or lymphoma. What happens to the white cells count, like neutrophils, could be, because that can be a pointer towards infections or a bone marrow suppression. The bleeding time is a very important lab test, but it has to be a very standard one. In the bleeding time ranges anywhere between 3 to 10 minutes. In some books we are going to find it 2 to 8 minutes. Prolonged bleeding time is a hallmark of platelet count defect and platelet function defect. For a bleeding time to be of clinical importance, a standard skin cut is made and the time is noted when it's going to stop. Because a bleeding time is basically a marker for platelet function, platelet number or vascular injury. The bleeding time normally ranges from 3 to 10 minutes, and prolonged bleeding time, as I already talked about, they are a marker of platelet function defects. The other side of the bleeding patient, the coagulation test is an important one, and it is done by collecting blood into a citrate which is neutralized with calcium ions, because that prevents clotting. In the coagulation test, the important tests are the prothrombin time, the partial thromboplastin time, the thrombin time. Once we have determined them, then the process moves on to finding out the correction studies, and then finally the individual factors assays, and at times you have special tests for coagulation. The peripheral films or CBC, the bleeding time, prothrombin time, and partial thromboplastin time is also called as a screening test. They are the basic screening test which we use in the beginning, and then we move on to more sophisticated tests. A little elaboration on the prothrombin time. That PT is the time when the plasma to clot in the presence of tissue, thromboplastin and calcium. The normal PT is 10 to 14 seconds, and when the PT is prolonged, it is a marker or a pointer to factor 7 deficiency, factor 5 deficiency, factor 10, and also the prothrombin and fibrinogen has an important bearing on it. On the other side, the partial thromboplastin time. The normal PTT is 30 to 40 seconds, and it is the prolonged PTT is the partial thromboplastin time is the result of factor 5, 8, 9, 10, 11 prothrombin and fibrinogen deficiencies. The thrombin time basically measures the decrease in the fibrinogen level, and dysfibrinogenemia is diagnosed on the basis of a thrombin time. And the normal clotting time is about 14 to 16 seconds. What are the common bleeding disorders in children? The bleeding disorders in children are the coagulation disorders, which are basically congenital or hereditary, and then we have an acquired coagulation disorders. Now, hemophilia and A and B are basically coagulation disorders, whereas von Willebrand disease is primarily a bleeding disorder. In the acquired coagulation disorder, we have factor vitamin K deficiency, we have some liver diseases, DIC, coagulation disorder caused by antibodies which are directed against coagulation factor, and at times massive transfusion results in bleeding disorder. The bleeding disorders in pediatrics, the platelet disorders are the thrombocytopenia, in which you have decreased number of platelets. The classical example would be an ITP or idiopathic thrombocytopenic purpura. Now in ITP, remember, this is a bleeding disorder, and this is the most common acquired bleeding disorder universally. I repeat, idiopathic thrombocytopenic purpura is the commonest acquired bleeding disorder in the world. And then you have other causes of low platelets count. Then we have the platelet count is normal, but functionally they are defective, which again can be congenital and acquired. And then we have some vascular problems. Again, they can be congenital or acquired. We're going to cite some examples for them. Now, in the hereditary or congenital coagulation disorder, though they are not very common, the classical example are A, B, hemophilia, and von Willebrand disease. I'm sure hemophilia has been comprehensively discussed by my colleagues in the lecture, so I'm going to skip about hemophilia A, hemophilia B, and you must have seen these pics of hemophilic patient and how problematical they can be for the individual suffering. Now, von Willebrand disease, the important thing that I need to emphasize is that von Willebrand disease is the commonest congenital bleeding disorder in the world, and this is the result basically of decreased level of von Willebrand factor, and this is the result of point mutation, where a single amino acid substitution in the genetic of the patient takes place, or there are major deletions of the sequences of the chromosomes. Von Willebrand protein has two important roles. It promotes adhesions of platelets to the endothelium, and it is also a carrier molecule for factor VIII, and thus it prevents the premature destruction of factor VIII. So in von Willebrand disease, there are two important findings: defective platelet function and factor VIII deficiency. And von Willebrand disease has three important types. It also has some subtypes, but for you it would be sufficient to remember that type 1 and type 2 are usually mild varieties of von Willebrand disease, whereas type 3 is more severe variety of von Willebrand disease. The clinical feature or hallmark of von Willebrand disease is that this is typically a mucous membrane bleed in which you have nasal bleed, and in girls of menstrual period it tends to have heavy bleeding, and the severity depends on the type of von Willebrand. What are the laboratory findings in a von Willebrand disease? So the lab findings in a von Willebrand patients is that the bleeding time will be prolonged, partial thromboplastin time will be prolonged, factor VIII would be low, and the specific test for von Willebrand, it's going to be low, whereas the platelet count in 1 and type 2 is normal, but in type 3 it can be low. The treatment basically depends on the severity of the condition, and in mild to moderate variety, nasal desmopressin is helpful, and in severe cases factor VIII and von Willebrand factor has to be transfused. This is a chart whereby you can draw a comparison, compare and contrast between hemophilia A, B and von Willebrand disease. The other coagulation factors are factor 11 deficiency, which is relatively rare, and similarly factor 12 deficiencies. In the acquired coagulation disorder, you can have multiple clotting factor defects, and the common clinical entities are vitamin K deficiency, liver disease, disseminated intravascular coagulation. At times antibodies are directed against the clotting factors, and at times massive blood transfusion results in clotting disorder. Vitamin K deficiency, as you remember, is a fat soluble vitamin. It is obtained from vegetables as well as the bacteria, and the gut synthesizes them. Vitamin K is an important in the synthesis of factor 2, 7, 9 and 10, as well as protein C and S. The vitamin K deficiency in the newborn period results in hemorrhagic disease of the newborn, biliary obstruction, malabsorption of vitamin K antagonists, and the routine practice of giving vitamin K to all newborn babies delivered. Liver is an important site for the synthesis of various factors, and any liver disease of significant magnitude results in defective synthesis of these. And remember that liver is also responsible for synthesizing factor 5 fibrinogen, and therefore dysfibrinogenemia, thrombocytopenia, functional abnormalities of platelets, and a functional defect in the spleen whereby the platelets are sequestered and their count remains low is a hallmark of liver. DIC is a serious condition in which there is a widespread deposition of fibrin within the blood vessels and consumption of coagulation factors and platelets, which results in bleeding from different sites and endothelial damage. The causes for DIC are infections, malignancies, hypersensitivity reaction, obstetric complications, widespread tissue damage, and various other causes. The DIC may be triggered by the entry of procoagulant material into the circulation, like amniotic fluid embolism. It is initiated by widespread endothelial damage in septicemia, and there is a widespread intravascular platelet aggregation. This is some of the pics showing skin changes in DIC and early gangrene which has set in the toes and lower. The lab finding in DIC is that the platelet count is low, fibrinogen level is low, thrombin is disturbed, prolonged, fibrin degradation products are very high, the PTA, PTT or the common pathways are affected, and fragmented RBCs. Coming to platelet disorders. The platelet disorders will be looked into by abnormal bleeding due to thrombocytopenia, which is decreased number of platelets. We talked earlier that the normal platelet count is 1,50,000 to 4,50,000. So by definition, any platelet count less than 1,50,000 is thrombocytopenia. Classical example is ITP, idiopathic thrombocytopenic purpura, and the important point to remember is that ITP is the commonest acquired bleeding disorder in the world. And then you have some other cause for decrease in the platelet count. In the platelet function defect, we have congenital and we have acquired causes. Irrespective of the platelets number and the qualitative function defect, the bleeding in platelet disorders is characterized by petechiae, purpura, and bleeding in the mucous membrane. Bleeding with the platelet count less than 50,000 and less than 20,000, there could be spontaneous bleedings also. Low platelet count can be the result of decreased production in the bone marrow or in the factory, excessive peripheral destruction of the platelets, what is happening in the market, abnormal distribution of platelets like in splenomegaly, and massive blood transfusion. Now this is an example whereby thrombocytopenia or decrease in the platelet count can happen in the bone marrow as a result of production, and second is as a result of consumption, what is happening in the periphery. Increased destruction of platelet, the immune destruction like ITP we have already talked about. The better name of idiopathic thrombocytopenic purpura would be immune mediated thrombocytopenic purpura, because the basic pathology of ITP is antibody gets coated on the platelets, and as a result they are removed by the macrophages in the spleen, and that results in lower number of platelet count. ITP is acute, as well as if it goes on for more than 6 months, we call it as chronic ITP. Acute ITP is pretty common in children, can follow infections or vaccination, and almost 80 to 90% of them recover without any treatment. 10% of the patients has a chance to go into a state of chronicity. And remember, ITP is a diagnosis of exclusion. These are the petechiae. These are purpura, which are bigger in size as compared to purpura. Petechiae. These are purpuras. Finally, the vascular bleeding. These are group of disorders characterized by easy bruising and spontaneous bleeding in small vessels in the skin particularly, and they tend to present again with petechiae and ecchymosis. They are the result of abnormality in the blood vessels themselves, and at times in the perivascular connective tissue diseases. In the congenital one, you have hereditary hemorrhagic telangiectasia, and in the connective tissue disorders, we have Ehlers-Danlos syndrome, osteogenesis imperfecta, Marfan syndrome, and so on. These are the telangiectasia or vascular pathologies in older individuals. The acquired bleeding disorder of vascular pathologies happen in septicemia, meningococcal infection, measles, typhoid. Henoch-Schönlein purpura is something which we clinically encounter quite often, and then there are other causes. Thank you very much. इसको बुलाना मरियम को.